All right, surgical board review. We're looking at high-yield clinical vignettes today. Let's get right to it.
Section 1. Rapid Fire Surgical MCQs. It's a continuous clinical vignette stream. First up, we've got a 34-year-old male with suspected abdominal tuberculosis who just had a laparotomy. It's post-op day 4, and he develops a high-output intracutaneous fistula. He's draining over 500 mils a day right through that midline incision. Now, he's hemodynamically stable, so what's your most appropriate initial step here? Are you going to go with A, emergency re-exploration, B, strict NPO and start TPN, C, throw on a negative pressure wound vac, D, start ATT monotherapy, or E, get an emergency percutaneous biopsy? And the correct answer is B. Your absolute immediate priority for an acute intracutaneous fistula is metabolic stabilization. You've got to contain that output and protect the skin. Making the patient strictly no per os, or NPO, cuts down on those GI secretions, while the TPN preserves their nutritional status. This is a perfect example of the SNAP protocol in action. S is for sepsis control. N is nutritional optimization, which is exactly what we're doing here. A is for anatomical definitions, basically mapping the tract once they're stable, and P is planning surgical strategies, but only if that fistula doesn't close on its own after months of medical optimization. Next vignette, we have a 65-year-old female presenting with 3 hours of severe generalized abdominal pain. Her blood pressure is 90/60, heart rate's bumping at 110. She's got a board-like abdomen and obvious rebound tenderness. So what is the most appropriate investigation to quickly confirm a suspected perforated duodenal ulcer? A, an abdominal CT. B, an erect chest X-ray. C, a barium follow-through. D, emergent flexible endoscopy. Or E, a trans-abdominal ultrasound.
If you guessed B, you're spot on. An erect chest radiograph is your fastest, most cost-effective screening tool here. It can pick up as little as 1 to 2 milliliters of free air. You'll see that classic subdiaphragmatic crescent of free gas. Now, if your patient is critically ill and literally cannot stand up, a left lateral decubitus abdominal X-ray is your go-to backup. And a huge pearl here, flexible endoscopy or barium swallows are strictly contraindicated in this scenario. Doing those carries an extreme risk of just punking more contamination right into the peritoneum.
Moving on, a 47-year-old male with decompensated liver cirrhosis comes in with massive hematemesis. BP is low at 80/50. You immediately start fluid resuscitation and an IV octreotide infusion. What's your most appropriate next step for definitive management? A, angioembolization. B, urgent EGD with pharocyl band ligation. C, laparotomy. D, dropping a Singh-Staken-Blankmore tube. Or E, an emergent TIPS procedure. Option B is correct. Once you've got initial fluids running and that octreotide on board, you have to get them an urgent endoscopy with endoscopic variceal ligation, or EVL. EVL gives you far superior initial hemostasis with way fewer local complications compared to sclerotherapy. And what about that Singh-Staken-Blankmore tube? Keep in mind, that's strictly a temporary bridge, maximum of 24 hours, and you only use it when an urgent EGD is either completely unavailable or unsuccessful. Next up, a 50-year-old male presents with an acute upper GI bleed. We're talking melena and coffee ground emesis. What's your preferred first-line medical optimization for a suspected bleeding peptic ulcer? A, an octreotide infusion. B, fluid resuscitation plus an IV PPI bolus and infusion. C, a highly selective vagotomy. D, submucosal sclerosant. Or E, a gastric balloon tamponade. You should be going with B. Aggressive fluids paired with high-dose intravenous PPI therapy blocks gastric acid output and pushes the intragastric pH above 6.0, which is exactly what you need to stabilize that clot. After that, endoscopy has to happen within 24 hours. When they scope him, they'll grade it using the Forrest classification. IA or IB means active spurting or oozing, which needs dual therapy. IIA is a visible vessel, watch out, that carries a massive 40% rebleed risk, and IIB is an adherent clot. All right, let's take that bleeding ulcer a step further. We have a middle-aged male with an actively bleeding posterior duodenal ulcer. Endoscopy successfully clips it, but 12 hours later, he has a severe rebleed. He's required 8 units of packed red blood cells over 24 hours. What is your definitive management now? A, repeat urgent endoscopy. B, a secondary IV PPI trial. C, angioembolization. D, emergency laparotomy to oversue the vessel, plus a vagotomy and pyloroplasty. Or E, total gastrectomy. The correct move is D. When a duodenal ulcer massively rebleeds despite primary endoscopic control, and they've needed more than 4 to 6 units of blood, you are going to the OR for an emergency exploration. Understanding the anatomy here is absolutely crucial. Posterior duodenal bulb ulcers erode straight into the gastroduodenal artery, which is a massive, high-pressure vessel. You have to oversew that vessel and perform a truncal vagotomy. But because a truncal vagotomy denervates the stomach and paralyzes motility, a pyloroplasty drainage procedure is literally mandatory to prevent severe gastric stasis.
Let's stick with this theme. Say a high-risk patient had an emergency laparotomy where they just did a simple oversewing of a bleeding posterior duodenal ulcer. No acid reduction procedure. 48 hours later, he massively rebleeds. Your next surgical option? You need to re-explore, re-oversew the vessel, but this time combine it with a truncal vagotomy and an antrectomy. This is a game changer because that combination permanently knocks out the primary acid-stimulating pathways, giving you the absolute lowest long-term recurrence rate at less than 1%. Next scenario, a 72-year-old male presents with sudden, massive, bright red blood per rectum. It's completely painless, vitals are stable, and anoscopy is totally negative. The most statistically common cause here, it's diverticulosis. Because there's no active inflammation upregulating local fibrosis, this type of massive bleeding is characteristically painless. And here's a crazy paradox to lock into your memory. Even though diverticula are way more common on the left side of the colon, the massive bleeding points actually come from right-sided diverticula in about 50 to 60% of cases.
Moving on to obscure GI bleeds, we have a 44-year-old male having recurrent episodes of maroon blood requiring transfusions. He's had totally normal EGDs, colonoscopies, and even capsule endoscopies. What is the logical next step to localize this active but intermittent bleeding? A. A technetium 99M labeled RBC scan. B. A repeat colonoscopy. C. A barium enteroclysis. D. An exploratory laparotomy. Or E. A CT angiography.
Option A is your winner here. The secret to this question is knowing your flow rate thresholds. A technetium 99M labeled RBC scan is incredibly sensitive for tracking intermittent obscure bleeding over a 24-hour period because it picks up flow rates as exceptionally slow as 0.1 milliliters per minute. Conventional catheter angiography, on the other hand, needs a much faster active bleeding rate, at least 0.5 milliliters per minute, just to show a contrast blush. Though, of course, angiography does let you embolize immediately if you spot it.
Okay, slightly different clinical picture now. A body packer is detained, and he's got cellophane drug packets scattered throughout his colon. What is the absolute indication for emergency surgical removal? It's structural packet rupture leading to acute systemic drug toxicity. The two absolute surgical mandates for intracorporeal drug smugglers are systemic toxicity or a mechanical bowel obstruction. And remember, putting an endoscope in there is strictly contraindicated. If your grasping instruments snag and puncture those fragile packets, you are looking at an immediate, fatal overdose.
Let's look at some imaging. You're evaluating a plain supine radiograph for a mechanical bowel obstruction. What specific finding confirms you are looking at the proximal small bowel, specifically the jejunum? You're looking for valvula convitaes. These are regular, closely spaced folds that span the entire width of the lumen, giving it this classic radiographic concertina effect. It's a dead giveaway compared to the distal ileum, which looks completely featureless, or the colon, which has asymmetric haustral folds that just don't go all the way across. Speaking of those plain films, say a resident is ordering radiographs for a suspected mechanical bowel obstruction. Which standard position is most useful to identify the specific anatomical level of that obstruction? A. An erect chest x-ray. B. A supine abdominal radiograph. C. A supine chest x-ray. D. An erect abdominal radiograph. Or E. A left lateral decubitus.
The correct choice is B, the supine abdominal radiograph. Laying the patient supine lets gas and fluid accumulate evenly throughout the loops, which really highlights those core anatomical landmarks you need to pinpoint the block's level and measure loop diameter. What about the others? Well, you'd use an erect abdominal film specifically to confirm the presence of air fluid levels, telling you it's an active block versus an ileus. And the erect chest x-ray, that's strictly to screen for subdiaphragmatic pneumoperitoneum. Following right up on that, if you need to capture multiple dynamic air fluid interfaces on a plain radiograph, which position is required? That would be the upright erect abdominal radiograph. It's all about gravity here. Gravity forces the heavier fluid down into the dependent loops, while the lighter gas rises to the top. To clearly see that distinct gas-fluid interface, the patient has to be upright so the X-ray beam shoots parallel to the ground. If you see staggered levels within the same loop, you've definitely got an active mechanical block.
Last vignette for this stream. The vermiform appendix exhibits highly variable positions within the peritoneal cavity. Out of these anatomical orientations, which is the absolute least common one you'll encounter in clinical practice or during a surgical exploration? Is it A, retrocecal, B, deep pelvic, C, pericecal, D, pre-ileal, or E, post-ileal.
If you said E, post-ileal, you nailed it. Taking a look at the matrix, retrocecal is by far your most common, at about 65%, followed by the pelvic orientation at 30%. The post-ileal variant is incredibly rare, seen in less than 0.5% of people. And keep in mind, position totally changes how the patient presents. A retrocecal appendicitis often lacks that classic right lower quadrant guarding. Instead, they might complain of flank pain. Meanwhile, a pelvic appendicitis might inflame the adjacent rectal wall and present with localized tenesmus or even diarrhea.